Thank you for joining us today. Pleased to introduce Julia Calder. She's doing a presentation on opioids and sugar, but not so sweet. So Julia was born and raised in Victoria, BC. She graduated with a Bachelor of Science in Pharmacology and Therapeutics from McGill University in 2015. She then returned back to the West Coast and graduated with honors from UBC's first entry to practice Doctor of Pharmacy class in 2019. She's since been working as a clinical pharmacist over at Royal Jubilee Hospital, primarily in vascular and general surgery. And she hopes to promote integration of clinical pharmacy into Island Health's addictions team upon completion of her fellowship here at BCCSU. So please go ahead, Julia.
Thanks, Mona. Okay, so this presentation, like Mona said, objectives were all sent in your email. I won't read them again for you, but importantly, I wanted to recognize how exceptionally lucky I am to be on the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations, and born and raised on the territories of the Lekwungen-speaking people. I have received an honorarium to facilitate a session, but besides that, I have no other conflicts of interest. So general outline today, first a really basic case, and then three main topics, first being opioids and weight, and to the different factors within them, reviewing any guidelines that are available, looking at potential mechanisms, and reviewing any new recent evidence, then looking into sugar content of different oat preparations, and then finally oat and dental complications. And I'd like to mention that I will be mostly focusing on methadone and Suboxone throughout this talk. I don't generally like to use brand names, but buprenorphine and naloxone can take a really long time to say, so forgive me if I say that instead. So our case is a 32-year-old female with opioid use disorder. She's in sustained remission and she's on methadose. She has 100 milligrams a day. That's been a stable dose for her. She comes in to see you feeling like she's gained unwanted weight and has several new cavities, thinking that this may be because of the methadose. She's heard there's a lot of sugar in it, and she's wondering whether she should switch to the sugar-free formulation and if this might help alleviate some of these of her concerns. So first topic, weight gain. I think that it's really important as clinicians. Sometimes we get caught up with adverse effects or things that may be really important to us, and they are important, like QTC prolongation, but sometimes forget about maybe things that are more important to the patient, and especially if this is going to implicate long-term adherence on a potentially life-saving medication. So if you just Google methadone and weight gain, you're going to start coming up with lots of people have posted about this in forums. It's a really common complaint. But I feel like this was something that was never really addressed during my education. And so I always found this really interesting, and it's something I wanted to dig into a lot more. So methadose's product monograph does list weight gain as an adverse drug reaction. There's no big section on it. Same with Metadol D. Suboxone's monograph does mention increased weight in their adverse drug reactions. Cadian, though, there's no mention. Up to Date does have this tiny little paragraph listed in adverse drug effects of long-term chronic opioid use. They do mention that methadone has this association noted in literature with weight gain, but Up to Date notes that there are no actual specific guidelines in how to manage this or potential risk. I did find that the College of Physicians and Surgeons in Manitoba, and their management of adverse effects for methadone does specifically mention weight gain, and they do have recommendations for clinicians. They mention that there is this association, but no causal link is known, and the recommendation is for education to the patient around nutritional habits, documenting a baseline weight for a patient starting on methadone, encouraging good dental hygiene, regular dental visits, and limiting sugar intake. This review article was one of the few others that had specific recommendations that I could find for clinicians. And these authors recommended reinforcing exercise and dietary habits with opioid-dependent patients, And they also make the consideration that methadone maintenance may put patients who already have diabetes or metabolic syndrome at higher risk of morbidity. And the authors recommend naltrexone as a preferred alternative. Now, this was published in 2011, BCCSU's guidelines, and I would never put a patient on naltrexone as first-line therapy for opioid use disorder without, there'd have to be a lot more considerations, I think, beyond weight gain or diabetes. So I wanted to look at some other articles. Especially in terms of mechanism, this is really interesting because I feel maybe this one is maybe taught in school, that opioids can inhibit the HPA axis and have downstream effects resulting in decreased testosterone levels, which can be associated with metabolic syndrome and insulin resistance, at least in men. But there's a lot more going on than just this. First thing that I wanted to look at was taste. So the opioid system is already involved in our day-to-day experience of food and how pleasurable we find eating, especially sweet foods and fatty foods. And there's lots of literature to support this. Patients who are opioid dependent have associations with increased consumption of refined sugar and increased cravings for sugar. And interestingly, opioid dependent patients, when given depot naltrexone, which isn't available in Canada, was found to decrease the rewarding properties of sugar. And this was a study looking at a sweetness tolerance test with different formulations of sugar and seeing how much patients preferred a different concentration. Patients on methadone may self-report greater preference for sweet foods and may also have a higher percentage of their diet comprised of sugar. And there was a few studies that pointed towards that higher doses of methadone might have a greater association with these, with preference for sweet flavor than those on lower doses. These weren't like primary outcomes from studies. These were more exploratory data, so taken with a grain of salt for sure, but it points towards maybe dose is correlated with the sugar effect. Going into a receptor-based theory and model, opioid receptors, there are three main ones. We have our mu opioid receptor, delta, and kappa. Each one has slightly different impacts depending on if they are activated or antagonized. And all three of these receptors have already been found in literature, particularly animal studies, to be associated with changes in weight, metabolic function, feeding behavior, and sugar intake. And I'd also like to just highlight how throughout the body, these are not present just in the brain, but in several different organ systems as well, especially the pancreas, which we'll get to later. So remaking our little model here by adding that agonism at any of these receptors may increase feeding, sugar intake, body weight, metabolism changes potentially. So therefore, full agonist opioids in theory could cause these changes into these mechanisms. And methadone specifically does have some weak antagonism at the NMDA receptor. And the NMDA receptor does have evidence as well, linking it into appetite. So maybe this is why methadone is more associated with weight gain, or we're seeing more studies about this. Hard to tell. Therefore, in theory, buprenorphine products like Suboxone, Sublocade, if they're only partial agonists at the mu opioid receptor, in theory, maybe this would not cause as much change in taste preference or weight gain, and possibly the weak antagonistic effects might also mitigate some of these effects. But if we're using only this model, then in theory, naloxone on its own would be a very effective weight loss drug and prevent any sort of sugar cravings. But we know that naloxone or naltrexone on its own actually doesn't have great evidence for weight loss. So there's got to be more going on than just this. This was an interesting study that was PET scans of about 30 women. They're around the age of 40 on average. Half of them had obesity, so a BMI on average was around 40, compared to the other half of the patients who did not have obesity, whose BMI was around 20. And using a radioligand of carfentanil, you can see that where carfentanil is binding, there is a much reduced mu opioid receptor density in the women with obesity versus the patients who did not have obesity. And these aren't patients with opioid use disorder. This is just highlighting this connection between the opioid endogenous system and weight gain, metabolism, maybe preferences. And so for weight gain, so interestingly, one second. So binge eating disorder and obesity, as previously shown, have these associations with mu receptor changes. And bariatric surgery and significant weight loss in morbidly obese patients have shown changes to the reverse to look more like the non-obese brains in terms of mu receptor density. As well as the mu receptor gene has associations with polymorphisms with opioid use disorder, binge eating disorder, as well as naltrexone in combination with bupropion has shown efficacy for weight loss. There is some evidence to suggest that there may be sex-specific differences in terms of methadone's impact on weight gain, that women may be more susceptible. As well as one study did show some exploratory findings that it may be the duration of time that a patient is on methadone that's associated with an increase in BMI, but not what dose they were on or what their serum concentrations were. Then opioids are also involved in our endogenous glycemic homeostasis and regulatory mechanisms. So there are mu receptors and delta receptors on the pancreas, and direct agonism of these can cause either hypo or hyperglycemia, and studies seem to differ based on whether blood glucose levels were already elevated or not, if opioids were being given like directly into the brain in animal studies versus like via peripheral IV. Animal models have shown that there are mu receptors located on muscle and they promote glucose uptake when agonized. And there is other evidence, again, mostly from animal studies, promote use, connecting opioids with reduced glycolysis and enhanced gluconeogenesis and potentially desensitization of peripheral insulin receptors. So as previously mentioned, there was one study I found that showed increased fasting insulin levels in patients who used heroin. I couldn't find any other studies to really replicate these findings, and this was done in the 70s. So again, take with a grain of salt. And not only hyperglycemia, but hypoglycemia is commonly found in case studies, specifically with methadone, occasionally tramadol, but methadone was the most common one. And these were in non-diabetic patients, and especially during, it seems, during rapid titration of methadone that patients are having these hypoglycemia episodes. And then to tie everything together between pain, taste, sugar, opioids, reward, you can see in newborns that giving sucrose can have mild analgesic effects. And there was one study that was looking at perhaps blood sugar levels may impact how well opioid analgesia works. But a lot of the literature that is available has really conflicting and contrasting reports, and a lot of the reasons behind this that authors suggest, as well as my interpretation, this may depend on whether these are long-acting agents or short-acting agents, the route of administration of the opioids, dose, especially if this is acute ingestion of opioids versus like chronic opioid dependence or ingestion, if the patient or subject already has diabetes, if they have obesity, if they don't have diabetes, as well as blood sugar concentrations when the opioids were being given. So this was an interesting study that used a population of 6 different First Nations communities in Northern Ontario, BC. And they looked at the data of when a Suboxone program was initiated in these communities over 2 years. So their primary population of interest was patients with type 2 diabetes and opioid use disorder who had been started on Suboxone and followed over 2 years, compared to patients in these communities who had type 2 diabetes but no opioid use disorder at all. So this isn't a comparison of Suboxone versus placebo in any sort of way. At baseline, you can see that the patients who had opioid use disorder and diabetes A1C was much higher than the patients without opioid disorder even before this program began. So this might indicate many different things. It's hard to tell why. Maybe this is from reduced engagement with healthcare system. Maybe it's because of the action of the opioids that they're taking. Who knows? So at the end of these 2 years, the patients that were on Suboxone had on average a reduction in A1C of 1.2% compared to the patients with type 2 diabetes on their own didn't really have any change in their A1C over these 2 years. And the authors do note that this is, of course, just an association, so we can't say that giving Suboxone lowers A1C in any sort of way, but again, maybe this is because they were more engaged with healthcare, they ended up going on other medications as well, but it seems like Suboxone was a good fit for these patients. There's a lot of other confounding variables, especially in these studies. Mentioning weight gain, if a patient was already underweight prior to starting on opioid agonist therapy, it could be considered a benefit that they have gained weight, like as a marker of like recovery in their life. Also, usually the disproportionate amount of patients that are of lower socioeconomic status in these studies. You can consider food security if a patient is now has their opioid use disorder maintained on a prescribed medication, maybe they have more funds that no longer need to go towards seek their drug of choice, that maybe they can spend that money on food. Maybe that's going to correlate to weight gain. And of course, a lot of low-cost foods are not of the best nutritional quality, and there maybe had no other choice of what type of food that they choose that they can ingest. A lot of refined sugars, which are associated with weight gain, as well as just the chronic stress of being in a low socioeconomic status is associated with weight gain as well. And some studies have even suggested that antipsychotic prescription rates are higher in patients of lower socioeconomic status. So a lot of these medications are also associated with weight gain. Then definitely looking at comorbid substance use is really not very clear in these studies, because if a patient is now on methadone and they're stable and abstinent from using fentanyl, maybe this correlates with reduction of maybe crystal methamphetamine use. And if that's an appetite suppressant drug, then maybe they're having some rebound weight gain with increased appetite again. Comorbid cigarette smoking is involved in taste perception and weight gain starting and stopping. And previously with antipsychotics, any sort of co-prescribed meds can influence this. Like if a patient is now engaged in care and they are now injecting their insulin more frequently, that might be causing them to gain weight. And I think that a really good study to highlight the impact of external factors was this study done in 2010. And this was a population in Switzerland. These were 2 different OAT programs at a psychiatric clinic for patients with multiple, mostly psychiatric comorbidities. They looked at the group that was on methadone maintenance and looked at their group of patients that were already on twice daily injectable prescribed heroin. Just to clarify, these weren't patients randomized into these groups, these were pre-existing. And they all filled out, or those who were willing to engage, filled out a self-report questionnaire asking about their experience of what they felt, what side effects of, and they listed many different common side effects listed in product monographs or common complaints from patients, which ones they felt was due to the methadone or the heroin that was being prescribed. And I think this is an interesting outcome because we can look at randomized controlled trials and see the rates of adverse side effects that are happening, but how much does that matter when it comes to a patient's perception of what they think something is associated with a drug? And because that can really influence how likely they are to continue to take it. The authors did note that because they looked at multiple different outcomes, so like weight gain, tiredness, sexual dysfunction, they reduced their significance level in order to try and account for this, but there still is the risk that these were false positives because of just the sheer number of questions that were asked. So at baseline, there were more men in the injectable heroin group, and treatment length was about half as long in the injectable heroin group. And average dose per day, the authors used a ratio of about 1 to 4 of methadone to diacetylmorphine. So these were considered to be about equivalent mean doses per day. There were very many frequently prescribed medications since this was a psychiatric-based population. The authors didn't provide any specific numbers around these for each group, but they noted that more patients on the methadone group were more likely to be prescribed benzos, antipsychotics, and psychostimulants. Of non-prescribed use, and this was self-reported in the past year, was quite similar between the two groups. About a third in each group were reported using cocaine in the last year, and very low amphetamine use rates, which is probably quite different from the patient population that you may see in BC. And non-prescribed heroin use rates were pretty similar as well. So of self-reported symptoms, neither of these three were considered to be statistically significant differences between the groups. And there were many others as well, but I just haven't listed them just to keep things simple on this slide. If anything, the injectable heroin group tended to self-report weight gain that they felt was due to heroin more often than the patients in methadone. And the patients in methadone were reporting more often that they felt like methadone was causing weight loss. So this is really highlighting here that it may not be the actual drug switching from, if a patient was using heroin non-prescribed, switching to methadone, it may not be the methadone that's making them gain weight. The authors mentioned their theories of why they think this is, that perhaps this is a change in lifestyle, or maybe it's reduced cocaine use, and that some patients considered this to be a positive thing because they were stabilizing their weight back to normal. There's a consideration that maybe these patients aren't as active because they don't need to walk around like all day to obtain their substance of choice. So maybe this is because they become more sedentary. So this was a study published in Nature in 2020. And this looked at metabolic and addiction indices in patients in a methadone treatment group and a buprenorphine treatment group. And this was, the patient population was from Massachusetts in the United States and recruited through local advertising. So it was a cross-sectional study, just under 60 patients. There was a quite heavy exclusion criteria because the authors were trying to exclude anything that might be associated with changes in metabolism or weight gain. So questionably applicable to the average patient population. Like not being on mirtazapine, I feel like I see that one prescribed really often with methadone, for example. A lot of other comorbid medical conditions that were also not included. So at baseline, or just in general, the patient characteristics were around the age of 40. There were more female patients in the Suboxone or buprenorphine group. And addiction severity index scores were considered about the same with their total craving scores for opioids. And interestingly, they on average would meet the criteria for moderate depression based on the Beck Depression Inventory Score. But there are a lot of confounding questions that I can see where this came from, like experiencing extreme fatigue or feeling like there have been permanent changes to your appearance, things like that. And both groups reported their daily physical activity is somewhere between, on this score, of very light to light. Patients on the buprenorphine group had not been on treatment quite as long as the methadone group on average. So the authors looked at all the patients, went for laboratory testing, looked at all the diagnostic criteria for metabolic syndrome. They also had a sweetness tolerance test, which I previously mentioned, where you get 5 different drinks with sugar of different concentrations given in a random order, and looking at first how you perceive the taste and how much you like the taste. And they also all had oral glucose tolerance tests and looked at subsequent insulin and glucose plasma levels. Of no significance, BMI was about the same in each group. Waist circumference was found to be the same with triglycerides, LDL, body fat mass, total body water, insulin resistance, and the sweetness tolerance test. So the groups had no changes, no differences in how they perceived sweet taste or how much they liked it. And again, this was a study where they tested multiple different outcomes, and I couldn't find anything that said how they tried to adjust for this. So there is the likelihood that the positive significant differences they found were simply due to chance. So of what was found significantly different, HDL on average was higher in the buprenorphine group. I'd like to highlight again though that there were more women in the buprenorphine group, and HDL on average tends to be higher in women, and at least the metabolic disorder criteria gives women a higher cutoff criteria for HDL. So that could be swaying these results. Systolic blood pressure was found to be higher in the methadone group, as well as they were found to have reduced insulin sensitivity. And there were more patients diagnosed with metabolic syndrome after going through all of these tests in the methadone group. But another caveat that the authors mention is that even though before the study started, before they looked at these patients, they excluded anyone with diabetes, 2 of the patients in the methadone group were actually ended up being diagnosed with diabetes after receiving this oral glucose tolerance test. So this can also sway the results. Then in a purely exploratory post hoc analysis, so just things to look at maybe in the future, no clear data to say these things are for sure. But the longer a patient was on buprenorphine, the greater, on average, likelihood of having a higher HDL and decreased craving scores. And duration of drug exposure to methadone was associated with higher triglyceride, MAP, fasting glucose, and A1C. No association with waist circumference, cholesterol, or LDL. So there's, with some methodological flaws, it's not a perfect study in any sort of way. There is some data here that's pointing towards methadone as maybe having worse metabolic outcomes, but of course, since it's just an association, it may be that patients who already who are more prone to developing an opioid use disorder because they already have a propensity to enjoy sugar and they develop metabolic syndrome. So it's not easy to tell which one came before, and there may be many other variables at play here. So in summary, opioid dependence is associated with metabolic syndrome, sweet taste preference changes, and weight gain. Methadone has the most published evidence of this association, and buprenorphine products might be a better option, but the evidence is there's not much to support this at this time. And just to re-emphasize again, these aren't controlled trials, so these aren't causation variables that I can deduce from this data. So like I said, so maybe there's this predisposition towards metabolic syndrome, or perhaps it's that patients who have higher weight end up with chronic pain secondary to their weight, and they end up developing an opioid use disorder. Who knows? So back to our case. So methadone, it could be what's causing her weight gain, but my recommendations would probably be to first investigate any dietary changes since she started on methadone, investigating maybe how her daily activity levels have changed, look at maybe has she started any other medications that we have clear-cut evidence is causing weight gain, and if we had to switch, you could maybe talk about, this would have to be a very collaborative decision, whether or not you wanted to switch her to Suboxone. So looking at the sugar content of these actual oat preparations. As a reference, dietary guidelines recommend no more than 10% of your calories in a day are from added sugar. And so for a 2,000 calorie a day diet, you can think of a baseline number as maybe like 50 grams or less before I get into the next slides. So if our patient is on 100 milligrams of methadose, this is 10 milliliters, and thankfully the college in Saskatchewan has really good data on methadone products and their sucrose formulations and calories, which I was able to get this data from. So every day she would be consuming about 16 calories, about 4 grams of sucrose, just from her methadone dose. In comparison, Metadol D, I believe BC's Pharmacare lists this as a sugar-free alternative, but it does have dextrose in it, so there's still calories involved in sugar, but much less than methadose, about a quarter. And there is a sugar-free methadose, but this requires special authority, which has no sugar. However, I would say it's pretty uncommon for a patient to be drinking their methadose straight because it's really sticky and it sticks around in the cup. So often they'll wash it out with something else. And Metadol D is required to be diluted with additional liquid on top of it to prevent diversion or injection use. So these are some really commonly used juices or things that'll be in the pharmacy for dispensing. And a lot of these are mentioned in the product monographs, specifically Allen's apple juice for whatever reason. So once adding these juices, you can see that this is actually much more sucrose than the medication itself. So overall, the difference here for our patient switching to sugar-free would be the difference of 4 grams of sugar a day or 16 calories a day. Suboxone does have artificial sweeteners, so unlikely to cause any sort of like weight gain or glucose changes based on sugar content. And Cadian has sucrose, which is involved in the formulation of the microspheres and the delayed action release. I don't have any data on the calories of this, but I would assume it would be very minimal. So back to our case, I would say that the formulation is unlikely to be the actual cause of any sort of weight gain or dental concerns. You could switch to a sugar-free formulation, but it needs special authority. You could also switch to Metadol D for just less sugar. More importantly would be to see maybe what she's diluting her medication with and using something that is a calorie-free and sugar-free alternative. So finally, last consideration for our patient are her concerns about dental caries and OAT. So this was a review posted in the Australian Dental Journal looking at patients with opioid use disorder and the impact of this on dentistry. The author's conclusions were that patients with opioid dependency may have higher carb and sugar intake, and this is linked to dental cavities. Opioids can cause dry mouth, but to an extent that's far less than something that's really anticholinergic. So maybe this is causing some of the dental concerns. Analgesia, perhaps these patients are not feeling like the early dental concerns, like the beginnings of the cavities, and they're not presenting until much later to the dentist. There's some evidence that shows that opioids do have some immunosuppressive effects. Again, the extent of how much this is actually playing a factor is, there's no data really to support or refute this. But I think more importantly that the authors mentioned is maybe previous experiences with healthcare system might be impacting how often a patient is even going to the dentist. So this was a systematic review looking at the association between methadone and dental caries. And of the studies that were included, it was a lot of case reports. There was only one controlled trial. This is from 2012. So the authors didn't have a lot of heavy data to go on already. They found that there wasn't any robust evidence to link sugar content of methadone to dental caries, and found that it was probably multifactorial etiology, so things we went over already, like causing dietary changes, having increased sugar diets associated with dental caries. So the authors recommend using sugar-free methadone, but also say that there isn't actually any evidence to support this recommendation. More recently, you might have heard about the FDA releasing a drug safety communication about potential dental problems being associated with buprenorphine medicines, Suboxone specifically, so sublingual buprenorphine. The FDA recommends that after dissolving the Suboxone, that patients should be swishing water around their mouth and then either swallow or spit that out, and also waiting at least an hour before brushing teeth after taking Suboxone. So where is this coming from? So there were a lot of case reports about Suboxone and dental cavities, tooth loss, other huge dental concerns. And so this was a pharmacoepidemiologic study, and this was a prospective cohort. And this was just done in the last 6 months it was published. And the authors looked at randomly sampled patients from over about 15 years. They all had to have at least 1 year of health contact prior to entry, and they had been newly started on Suboxone or transdermal buprenorphine, so like a Butrans patch, or oral naltrexone. And the data was derived from a pharmametrics database looking at prescriptions dispensed in the United States, as well as diagnoses. So over 20,000 patients on Suboxone were included, and these were compared to transdermal buprenorphine. So this gives us an idea of whether it's the actual buprenorphine product that is causing dental cavities. So based on some of the mechanisms previously mentioned, like is it opioid-induced immunosuppression, or is it the xerostomia from opioids, or is it the route of administration, which gives us a little idea here. Oral naltrexone gives us some idea too if it's the naloxone component that is the concern. So their primary outcome was time to first adverse dental event, and secondary outcome was specifically dental caries or tooth loss. And they followed up these patients until they had one of these events, or until health coverage was terminated, or they changed drugs, or until the end of the sampling period. So we can see that the Suboxone group had a higher incidence per person years ratio than the patients on transdermal buprenorphine or oral naltrexone. And these were statistically significant elevated hazard ratios for the Suboxone in comparison. For their secondary outcome of dental caries or tooth loss, we have the same thing again with these elevated hazard ratios that were found. And so the authors are looking at this and seeing, well, then it seems like it's not the actual drug itself, but the route of administration is what this data is sort of pointing towards. And the authors conclude that it may be the acidity of the composition of the Suboxone tablets. So I looked into Suboxone's monograph, their non-medicinal ingredients. A lot of these are, you know, fancy words here, but a lot of them have to do simply with dilution of the drug and formulation, but the citric acid is involved in how quickly the medication can be dissolved into the pH of the saliva. So dissolution and absorption properties is why there's citric acid in here. And the thinking is that if you're keeping a really low pH medication next to your teeth for a prolonged period of time, then maybe this is like taking a gulp of like Coca-Cola and then just keeping it in your mouth and like gargling with it for 10 minutes might result in some enamel decay and put you at risk of having dental cavities. So for our case, the evidence doesn't really prove that it's the actual methadone that's causing dental cavities. It may be dietary changes that may be more of the impact. It's recommended that she rinse her mouth out with water after having methadone in the morning. Choosing a sugar-free beverage when diluting methadone. Maybe you could switch to Metadol D or sugar-free methadone. So final summary and recommendations. Chronic opioid use, as we've shown, associated with weight gain, differences in sweet preference, metabolic syndrome. Unclear what the mechanisms are, probably multifactorial. It might be from the opioids themselves, predisposition to substance use disorders if you already have metabolic syndrome, overlapping gene polymorphisms, as well as lifestyle changes with stabilization on OAT, which is really highlighted by that study with the patients on the injectable heroin program. Buprenorphine might have a more favorable profile metabolically. And the sugar content of the actual medication seems unlikely to me based on this data to have any significant effects on dental caries or weight consequences. But besides that, sublingual buprenorphine tablets, it seems like the evidence is pointing towards this is causing an increase in dental caries, possibly due to the acidic formulation, which is necessary for the sublingual medication to be dissolved. So application to everyday practice, consider doing a baseline weight. I think there's nothing wrong with that, and maybe an annual weight in your patients who are starting out or with opioid use disorder. I think if a patient has really poorly controlled diabetes or undesired weight gain, and this is a major concern, this could be a discussion point for Suboxone. And again, I don't think the evidence is strong enough in any way to just say we should switch everyone to Suboxone because of this. This would have to be a collaborative decision. Rinsing mouth with water after methadone and Suboxone. This might be a lot of steps if you're already looking at it's hard to keep a medication in your mouth already with the Suboxone for 15 minutes and then no swallowing and then telling them to rinse their mouth after. So maybe after a patient's been on Suboxone for a while, you can start making this recommendation if they're comfortable about how they take it. I think encouraging dental hygiene, nothing wrong with that. Encouraging exercise, healthy dietary choices. And a lot of references that you can go through at your own time. But ready now for any questions.
Thanks, Julia, for the presentation. So just wait for some questions. Very applicable to our patient pool for sure. I'm just going to do like a 10-second. If there's no questions, we can wrap it up, and you know where to reach us in case there are questions. Okay, it looks, oh, here we go. Great presentation. Here we go. So there is one question. What type of research would you design to answer the question around the differences in weight gain between methadone versus bupe treated subjects if you were to design a study?
I mean, in an ideal world, you would have a patient like a placebo population and a patient on methadone and Suboxone, but ethically, I can't see any way that study would ever be undertaken when we already know that there are life-saving benefits to being on opioid agonist therapy, and it would be really unethical to give someone a placebo who has opioid use disorder. So I feel like we're going to be stuck with the data we have and observational data and associations only.
Thanks for that. And what about, somebody's wondering, any information on a combination of opioids and amphetamines to look at weight gain?
Yeah, so I touched on this a little bit, that you know, stimulant use is associated with weight loss, but there were no studies that I found that were looking at specifically comorbid use. So there was none that I found.
And have you ever come across yourself any, or you know, in the studies across methadone-induced hypoglycemia?
I have never seen it, but I did see quite a few case reports, and these seem to be a lot coming from patients with who had cancer, who were being placed on long-acting opioids, so they were put on methadone. And especially during this rapid initial titration phase, we're going to have hypoglycemia. Yeah, other studies I saw with tramadol. So maybe there is more of the mechanism involved with maybe some like serotonergic effects, since both of these can have like additional side effects or additional targets of action. So maybe that's more the cause, but hard to know.
Thanks for that. So it sounds like, would you recommend perhaps counseling side effects of hypoglycemia at times with some of these patients?
I think that it's hard because there's so many similar side effects between methadone and hypoglycemia. So like sweating, maybe like tremor could be confused with myoclonus, dizziness. So I don't think that it's something that I would specifically counsel about, but I think that if you are in an inpatient setting and you were doing like a rapid dose escalation of methadone, and a patient was like really complaining of dizziness or like feeling really unwell, I don't think it's harmful to just do like a quick blood glucose, like finger prick test. But I don't think it would be, the data is enough to support that as like a routine practice.
Thanks for that. Looks like that is the end of our question periods. So no more questions. Thank you very much. Have an enjoyable rest of the afternoon. We'll give you back 15 minutes of your day.